Ladies and gentlemen, most welcome to International Aniridia Day and to this seminar. This seminar today is made by Aniridia Europe, the Federation of Aniridia Associations of Europe, and this is in collaboration with Aniridia Net. The Aniridia Net is a program, a European program funded by the COST Action, and the COST, that stands for European Cooperation in Science and Technology. And this is a part of a serial of webinars we have had during the spring, and it will also continue during the autumn. And the idea is that we want to talk about different perspectives in relation to aniridia and aniridia-related conditions. We have today two very distinguished guests who I will introduce. We have with us Professor Dominique Brémond Gignac, who is the head of the ophthalmology department at the University Hospital Necker-Enfants malades in Paris. She is also head of several centers for research, one of them for rare eye diseases called OFATRA, but also we have her in many different commitments. Not to forget that she also is an executive member of the World Society of Pediatric Ophthalmology and Strabismus. I also would like to mention that she is the chairperson of Aniridia Europe's scientific committee. The other distinguished guest we have today is Professor Dr. Barbara Käsmann-Kellner. She is from Homburg, Saar, the Klinik für Augenheilkunde in Universität des Saarlandes. Barbara is also a very profound researcher, and she does research within ophthalmology, genetic ophthalmology, pediatric ophthalmology, and also low vision services. She has been very long, more than 30 years, committed to support also support patient groups. And just as two examples, I can tell you that she have supported the German albinism support group for more than 25 years, but also for 10 years the Aniridia Vage support group. But she is also, as the Dr. Gignac, also very much into research, and she has actually done something very honorable. She has secured funding in 2.5 million euros for establishing of a center of research for aniridia and limbal cells research in 2019. I, who am speaking, my name is Neven Milivojevic, and I am here on behalf of Aniridia Europe. I was the former vice president, and I will have a very low key because now we are going to listen more to the exciting part of the seminar, which means listening to our guests. So with this brief introduction, of course, I should also mention that Dr. Käsmann-Kellner is a member of our scientific committee in Aniridia Europe. With that said, I'm very pleased to hand over the word to our guests. The plan for today will be like this, that we will have a dialogue between our doctors and scientists where they will put different questions to each other. Questions we have together picked out, which we think would be of most interest to you as a listener. We will about 20 minutes before ending this seminar, about 20 minutes to 7, we will open up for questions. It means that you can write questions in the chat functions, and then we will try to pick up a few questions also from the audience to put to the doctors. But as said, we will start with the doctors, and I would like to give a word to Professor Barbara Käsmann-Kellner.
Thank you very much, Neven, and I would like to welcome all listeners and all viewers to this webinar. I'm honored to be part of it, and I say hello to Dominique, and I would like to ask you the first question, which is, what do I do when aniridia is diagnosed in my child, and what is essential to be done?
So thank you very much, Barbara. It's a pleasure. I hope you hear me well, and
I do.
welcome to welcome to all of our listener. And so that's a very big question when we have a child with an aniridia, congenital aniridia diagnosis done. And so I can understand for the parents, this is a big announcement, and they probably don't know exactly how can they can handle that. And so I think the most important is to have a reference center that can handle all the diagnoses and explain how they will go with their child. And one point is important is to be sure of the diagnosis, to see an ophthalmologist, and if necessary, to be referred to a specialized ophthalmologist in rare disease, for instance, or in aniridia, of course, for sure, as we are together, but not so easy in some part of the world. And when the diagnosis is sure, it's different if the child is in a family or its child is just the only one, though, which say that as a sporadic case. It means that the only child in the family to be affected. And we have first to eliminate a genetic problem that could be wider and affecting other part of the body. And so that's a good point. The second point is to make a complete workup of the child. And in this workup, to be sure the pressure, the lens, the eye is affected, but not with urgent problems, like could be congenital glaucoma or cataract, but a large cataract. And so this is very important to have a good workup and to be sure that we are on the good way to treat the child and to go further regarding all the things to be done. So after that, I think the family can understand the disease, and also it's important that the family just go and have explanation and can understand. And in this point, I think associations are very, very important because they can support the families and they can help in understanding, they can help in making the relations with the specialized ophthalmologist, the specialized geneticist that could help the family to help the child also. And so it's really important to have all of these to be in a good mood. To have the child in the better condition to be treated and to be followed. I hope you agree with that. And I don't know,
I
Barbara,
absolutely.
if you have something to add also. And I think if you would like to, I can ask also another question because we can discuss.
Yes, go ahead.
So, in this congenital aniridia, when the diagnosis is made, is what are the subtypes of aniridia, and are there any systemic manifestation of in PAX6 mutation aniridia, for instance?
Yes, thank you very much, Dominique. You all know the Aniridia phenotype, which was called isolated aniridia. And you know, as a contrast, the Wager syndrome, Wilms tumor aniridia, genitoureteral anomalies, and retardation. These are well known. What is not well known actually is that aniridia, the so-called isolated aniridia, often has systemic manifestations, and therefore we tend to name this PAC6 syndrome. And we have metabolic findings like diabetes, like obesitas, the people are a bit overweight, like disturbances of melatonin and the sleep rhythm, and you can have abnormal anatomical findings. Just today, I saw a little girl who had a major brain anomaly with a good development, fortunately, but it was shown by MRI that one part of the brain was missing, which connects all the both hemispheres of the brain. You can have hypoplasia of certain brain structures, and of course, what is discussed is that if there is an association to autism and hyperactivity syndrome. And this is a discussion which at the moment is in Germany quite open, because there is the suspicion that aniridia has a higher prevalence of autism and hyperactivity in the children. And I do agree. And if you look at the genes, PAC6 influences, there are many genes which are associated to autism spectrum disorders. So what I would really like to bring into the minds is that the so-called aniridia, isolated aniridia, is not isolated, but may have other complications. So a neurological and a neurodevelopmental workup would be very, very sensible. Of course, the other thing is the Wager syndrome, where you have to check for the nephroblastoma from a very early infancy on. And if you look at the development, not everything in aniridia is related to low vision. There might be other developmental deficits which are not related to low vision. So be aware that there might be other problems contributing to the so-called PAC6 syndrome. Would you like to add something, Dominique?
I think you are absolutely right, and this is very important because when we talk about congenital aniridia, the title seems to say that there is only iris problem. And of course, this is a panocular disease. It means that all the eyeball is affected, but also it can be a systemic disease when it's associated in syndromes, as you explained very well. And so that's why the workup is really very, very important. So I think you explained very clearly why a workup on systemic associated problems could be found and so must be researched.
Thank you. Well, I often get the question concerning contact lenses. This is a point which needs discussion, I think, and I would like to hear your opinion about contact lenses.
Yes, of course. Well, as we said, so that's a panocular disease. It means that it's not only the iris the problem. And of course, we would be very, that's a temptation to go to contact lenses with, for instance, iris replacement. I mean, Tinted on the contact lens. But we must be aware that congenital aniridia is also limbal insufficiency. So limbal insufficiency, which is a very complex term, means that the cells that regenerate the cornea could be widely affected. And for sure, even if in infancy these cells are all right, it becomes very bad in the life. So when the child or when the even young adults just wear contact lenses, I mean regular contact lenses, they can affect the limbus. So that's not a good option, and they need to wear glasses, and they need to find something different than contact lenses, because the eye is dry also, and so the contact lenses will not fit well. At the opposite, there is also possibilities with scleral lenses, which is different. These lenses are wider lenses, they are not on the limbus, and they can be very useful for severe corneal problems. And so that's different. So, in summary, contact lenses for my thinking are contraindicated in congenital aniridia because it affects special cell that regenerates the cornea. But when the cornea goes affectedly severely, we can go to scleral lenses, which are different with rigid lenses and could be very useful to help the cornea to stay clear. I don't know if you have any other advice, and I will be happy
Now,
to hear
what
you. No?
my opinion is that especially tinted contact lenses are disastrous for the limbal area. So because the paint goes into the limbus and it promotes the new vessels running into the cornea. So that should be avoided. What we sometimes do, especially in adults, is so-called bandage contact lenses. If they have a severe surface problem with the cornea, with open areas of the cornea and much pain, they sometimes wear big bandage contact lenses, which might be quite beneficial. And as they are quite big, they don't rub over the corneal periphery so much, and they might be quite beneficial for the patients. But otherwise, and especially in children, I would strongly disagree with contact lenses.
Okay, so I'm very happy because we know each other. We have the same advice, so that's very good. And I have some question for you, Barbara, if you accept that. Is there any proven prevention of corneal affection or opacification in congenital aniridia?
Well, the problematic word is proven, and up to now we don't have any proven help against the progressive corneal opacification, which may already start at young infancy. What I always suggest to do is to lubricate the cornea, to put fluid on it, and to put nourishment as an ointment at night. And I have the impression, and I'm caring for aniridia children since quite a few years, that this may perhaps slow down the corneal opacification, but it's not a proof. And limbal stem cells is another treatment option which is widely discussed and which has difficulties in aniridia patients because both corneas are affected, and you have to get foreign limbal stem cells, and they need immunosuppression as well, and so that is still not established as a treatment. I would really suggest a continuous local treatment for lubrication and to keep the corneal surface intact. Dry eye is a major problem, and that can be alleviated by artificial tears and ointment. Always be careful that all eye drops are non-preservatives, no preservatives in any eye drops for aniridia. And another option is distributed by the hospitals, may be serum eye drops. They are made from the own blood, and it's a very high nourishing index with the serum eye drops, and so I would advise this, especially in those patients who have surface problems.
Yes, very good. I agree also. It is always very difficult to have a scientific proofs, and
Yes,
for a disease that evolutes in the time, and so. But what is known is that as possible in congenital aniridia, we need to prescribe treatment preservative free, because we
definitely.
know definitely we know the toxicity of the preservatives, and so be aware to have the maximum of the eye drops preservative free, and so it will be much better for this. Um, and I think also these special cells, these stem cells that are getting bad with the time, could be helped by the serum, the autologous serum, and this serum is very good also. But of course, that's a problem because we have to take blood every month, and so we cannot do it very early. So it's reserved for corneal opacification on that are going badly, I think. But
Right.
it's a very good point, and I really agree with this, and I
May
think
I put a question to you, doctors? In this, when you speak about these drops, of course, as an aniridic, we are very used to taking drops in all different kinds, morning and days and evening and night. But I have a question, which I think you maybe will come into also to speak a little about glaucoma, and I wonder if it would be possible for you to just, when you speak about this subject, maybe to reflect a little about a lot of us, we have to take medication for glaucoma. But we know that this medication is not good for all parts in the development of the eye, especially the outer. And also now, I've seen this research recently actually saying that they found that there's about 20% of people who they found glaucoma in. So it's always about a balance. And I haven't seen any results on research in terms of how to balance the treatment, or to say preventive treatment for glaucoma, and at the same time not taking medication which can have a bad influence of other developments in the eye. I don't know if you understand my question. I wanted just to add it into your talk when you speak about glaucoma.
Okay.
would you like to answer, Barbara, first?
I can answer, and the most important thing to say concerning glaucoma is that if you have glaucoma and the optic nerve is damaged, this is irreversible. So you can become blind from aniridic glaucoma, while with cataract and cornea, you always have the options for further surgery. But with glaucoma, and especially overlooked glaucoma, there is the risk of becoming blind over the time. So there is the need to treat, and you say, if in doubt, treat. And there are big problems in diagnosing glaucoma media, especially in children, as the compliance is not so good. But I suggest to measure the eye pressure as young as possible children, and to measure it regularly. This is, or at least in Germany, sometimes a problem because not all ophthalmologists measure the eye pressure in infants. In addition, a problem with diagnosing glaucoma is that the children cannot perform all these high diagnostic tools like visual fields or pentacam, looking at the corneal thickness, or doing images from the optic nerve head. So some exams which are essential to diagnose and to follow up glaucoma are not possible in children. The problem as well is due to the nystagmus and due to a possible corneal opacification. And there, even in adults, it may be possible that the glaucoma is overlooked. So concerning the eye drops, one has to use preservative-free eye drops, which is very important. If you have higher eye pressures, I would take an eye drop, first a monotherapy, just one agents, and then perhaps a combination. But if you go up to 3 or 4 medications, then it's the time to ask if surgery would not be the better option, because too many eye drops is just too damaging for the corneal surface. So what would you think, Dominique, about doing surgery in glaucoma?
Yes, I think I agree. In diagnosing, there is one problem, and we must be aware of it. Most of children and even adults has a sick cornea. So in sick cornea, the pressure could be less than that can be
Measurement.
measured. So measurement, exactly. So this is important to be sure there is a real glaucoma. And when the treatment is done, of course, the treatment must be as possible with preservative-free. Some molecules have really no preservative, and we must choose them, and not the other with preservative. And also, when the treatment is very high, I understand that, and I really understand very well. I think this is the time for surgery. Even if we know that the surgery is not so easy and not so perfect, but it's better sometimes to go and make the surgery. And I do perform this surgery more easily when the treatment is very, very wide. And I understand that.
Yeah.
Really, I agree. You're absolutely right with that.
What about the prevalence of glaucoma? I was just a bit surprised that Neven said it's 20% in Aniridia. From a gut feeling of my patients, I think it's a higher prevalence. What is your
Very
impression?
higher. Yes,
Yes.
much higher prevalence, which can be, I think, the statistics may be, the epidemiology must be not good, because it depends on the age. At what time you look at the prevalence of the glaucoma, it's not the same. If you look at the prevalence of the glaucoma at 3 years old, of course, could be 20%. But if you look at the prevalence of a glaucoma at 60 years old, of course, this is not the same, even at 40 years
Sure.
old. And it's probably something like 70%, I think. And so we must be aware of it, because the patients must control that pressure. They must control it every year, at least for adults, and every 6 months for children, to my thinking. And so this is very, very important to be aware of it, because a treatment can be very efficient to keep the vision, and not have a bad vision due to glaucoma. So that's very
Yes.
important. Yes, of course.
I even advise for the children every 3 months, if it's possible, with the
Yeah, when
local
they are very young.
ophthalmologists,
Yeah, you're
and
right.
with adults every 6 months. So that is the scheme I follow.
No, at
Well,
least
there are,
I said at least, because sometimes people have
yes.
troubles to find out for an ophthalmologist, and for children much more, also for younger patients, of course.
Let me quickly go back to the corneal surface and another question. Some children with aniridia have cataracts which need surgery. And in very, very small children, you usually cannot put an intraocular lens in, but you need, again, the contact lenses. What is your action in pediatric and in adult cataracts, Dominique?
So first of all, there is not so many cataracts to be operated very early. There is some, early cataracts, of course, but not so many. And so if you have a cataract, not occluding cataract, you don't have to operate it. So it's better to wait and to see how it's developing the vision and to operate later. So in aniridia, I think if we can skip the cataract surgery earlier, so that's much better. Sometimes you have no choice because the cataract is occluding, of course, the actual visual axis. And so if you operate it, I will prefer glasses to contact lenses, because I think it's much better, even if the glasses are thicker. But usually also they go to have myopia, which
Reduces that.
reduces the glasses. So I try to avoid, in this case also, I try to avoid contact lenses. And I try to wait the maximum to go to the surgery. The same in adults. I try to see if there is really an impact of the cataract on the vision. And the only point when I go for earlier surgery is when the cornea is getting opacified. And so I know that that's the time to go and take off and make the surgery of the lens with IOL, with implants for correcting the vision. And in the meantime, to try to keep the clearest cornea as possible.
That's right. Yes, that's how we do
And
it as well.
okay,
What
very good.
about a question we often get asked about artificial iris implantation during cataract surgery?
That's a very, very good point, because of course it looks very attractive, and it is not. It is the main problem, its main complications coming after this iris implantation. And so we have the experience, and we see that, of course, at the time, patients are very happy because it seems they think that they have been corrected in their disease, but it's not true, because the iris can induces glaucoma, and these glaucoma are very difficult to treat after. And so that's why we must be really aware to explain to patients, no, that's not a good option. This is a good option for non-congenital aniridia, like traumatic aniridia, but it's completely different. In congenital aniridia, the angle of the eye, where, when the glaucoma is the resorption of the aqueous humor. And this is very important to understand, that is not a good option and should be avoided, because we see the complications. And so we must do in another part, a different
That's
way.
right. And these artificial iris, they look very perfect, really. We use them in traumatic aniridia, but we absolutely refuse them for congenital aniridia. Yes, due to the same reasons.
Exactly. I have a question for you. But just before that, there is scleral and bandage contact lenses, and they just want to know what is the difference, which is really different. Would you like to answer for it, or would you like?
Go ahead.
You can answer. Okay. For scleral lenses, this is rigid lenses, and they are used when the cornea is getting opacified, and when the cornea is dry, because this scleral lenses is larger than the limbus, and keeps the cornea very humid inside, because they keep lacrimal tears in it. And so this is very appropriate for an early opacification, and so it could be very useful for this cornea that are getting bad. this is rigid, and so it's not so easy to be adapted. But when you are adapted, it's very good. Bandage is different because usually they are soft lenses and could be used very punctually when we need to cover an ulcer of the cornea. It means when there is a defect on the cornea, it's like a bandage like we can have on the skin, and it could be the same way. So they are different.
That's right.
If you don't I have a question for you. What about the research in congenital aniridia? Because we've seen there is many ways of problems in this disease, and so I'm sure you will explain there is many ways of research.
There are many ways of research, and especially with the cost action, which Neven has mentioned before. There are several groups working in the research of aniridia. Some are working on the genetic aspects, which aim to put a gene into the cells and to restore the functions and the anatomy of the eye. Some groups work on stem cell treatment as well in combination with genetics. Then there is a group where we both are in. We try to establish guidelines for aniridia. And I think the efforts of all labs, there are over, I think, 25 countries in Europe involved in aniridia research just now via the Aniridia net. And I think the combination of all research parameters is very, very fruitful. And it's not only medical doctors which are involved. There are biologists, there are geneticists, there are microbiologists, and it's a really multidisciplinary effort to do the research in aniridia.
May I add something into that? Actually, this is so fantastic, I have to say. I mean, 20 years ago, there were barely no research whatsoever within this field. And even in the profession, quite few people were very aware of these aniridia and aniridia-related, especially the related syndromes. And what is unique, I have to say, and it's not my contribution only, but the unique thing is that actually the patients, the people living with aniridia and their relatives, they took very, very strong commitment and hard work to spread their interest amongst researchers. And then thanks to committed people like you two and others, we managed in 20 years to build something which is really, if we look at it now, and if you consider 20 years that was basically nothing, is really amazing, I have to say. So thank you for everybody who've been contributing, but also to share the value of this commitment that you two have. We have got a question I wanted to put you, if I may, from the audience. Just, it's a very quick question, and then you can continue. It was somebody who wanted a clarification. You mentioned scleral and bandage contact lenses, and we got a question if you could explain the difference.
No, not scleral. It's scleral lenses or bandage lenses.
Yes, yes.
But
so could you explain the difference, please?
She just did, actually, Dominique.
Yeah.
She took the question from the side and she answered it.
So sorry, perfect. Sorry, I'm sorry about that. Great.
No, it's very good, Neven, because I just would like really to add something very special, because Barbara and me are in the association, in scientific committee, Aniridia Europe, and I'm also involved, and Barbara, I'm also involved in French Generis Association also, and Barbara in also in Germany. And this is very important to have the input of association of patients and researchers and ophthalmologists and doctors in geneticists. And so that's why this is very good today, because we are working in the same way. And this is very important because we are trying to find solutions. And we found solutions. I mean, not, of course, a big solution for patients, because this is not magical. But for instance, we know that today preservative are toxic, so we need preservative-free drugs. But also we work in genetics, and I work also in gene therapy in retina, but now we work on gene therapy on aniridia, congenital aniridia, PAX6 mutated. So this is important to understand. This is a real it's a real movement of all the ophthalmologists, researchers, and association of patients, and we all have a contribution for it. So it's very important to be to be all together and work in the same way.
Yes, and as you see how Aniridia Europe developed, and many European countries now have their associations and their support groups, it's just amazing what happened during the last 10 years.
Yes, it is, but it's also thanks to your commitments. Now we got another question from the audience, and it's related to drugs or to drops, eye drops. I don't know which one of you would like to answer it. Can you see it, the question?
I see the question.
Yes.
Yes.
Would you like to answer first, Barbara, and then we'll complete if you want. Go
Okay, I will answer that. Coenzyme Q is quite a novel medication, which for the optic nerve had, because it's said to be neuroprotective. That means that the optic nerve might be protected from further damage. There is no proof of it, but the mechanism of the drug suggests that it might be protective for the optic nerve. Vitamin E and B should be taken as supplements in case there is a low level of it. Please do not take vitamins just for the sake of the vitamins, because you can overdose quite a lot. Trehalose, do you know that, Dominique?
Because yes, of course. Trehalose, it's eye drops, and this is preservative-free eye drops, and this is lacrimal tears.
I see.
But it is a very sophisticated drug, because it fights against dryness of the ocular surface. So it could be very useful even at the beginning to preserve the ocular surface. And this is preservative free, so that's a good medication, of course.
Yes.
So maybe I don't know if you have another question, or if you want to, I give you a question, Barbara.
Yes, please, if you have a question. If you have a question.
Yes.
Please, Professor Gignac, you'll continue.
Okay, so I have a question for you, Barbara. What is important concerning fitting of low vision aids in aniridia? I think you have a lot to explain.
Yes, that is as well as many things in aniridia. This is a problematic topic, and I know the experience from stable congenital eye diseases like albinism. They remain stable; they don't get any complications, and the fitting of low vision aids is much easier because you can rely on the stability of the disease. While in aniridia, you always have to be aware that things might change to the worse. And therefore, you have to adjust the low vision aids accordingly, according to the development of the visual acuity and the visual field defects. What I always find important is to start early, to prepare children for mainstream school, and to even introduce small children like 3 or 4 years with a magnifier which lies on the books, and then they can sort of grow into the use of low vision aids. And what I think is very important as well is not to confront the children when they start school with the big devices like CCTV and camera to the table and to the blackboard. So start with small and efficient tools so that the children can really use them and are motivated to use them. Some children are a bit hesitant to use low vision aids at school, and in my opinion, it has helped to introduce the low vision tools to the class. Everyone can have a look through the magnifier or through the monocular, and then the interest of the children is satisfied, and the child can go ahead and use it just as normal. So 3 messages. Aniridia needs probably more low vision fitting than other stable congenital eye disease. Start early, but think of the motivation of the child. It is very, very important that the child sees that it makes sense to use a tool. And the second is don't overdo low vision aids fitting in young children. They need to grow into the use of electronic devices, and especially do encourage the use of new media. They are not so new anymore, but like handy smartphones and tablets, they are very, very good as low vision aids as well.
Thank you. Thank you. I have a question for Dr. Brémond Gignac. I wonder, I know you are involved in developing the European guidelines, and I know there is a work in some countries. We have national guidelines in relation to aniridia in Spain and in France and in Italy. But I know there is a work going on for some possibly common European ones. Could you just tell us a little about how is that work going, and will we see some European common ground on this field, within this field?
Well, that's a very good question, because of course we had guidelines worked with Generis Association in France, and there were also guidelines in Spain and in Italy, and I know there was a work also in Germany. We work at the time on guidelines for Europe, and this is quite complicated because there was not really a very good structure for it, but we are trying to structure it, and we are working very hard in the group, and Barbara knows it because we work together, and so we hope to have quite simple guidelines to be distributed. I don't know exactly when. I hope by the end of the year or next year. And because we work together, we must be on the same line, and we have some questions that can be useful for patients. And I really think that the guidelines are useful. I see in France, and it's accessible for everybody, and they are very, very happy from the general practitioner to patients also, because they can find some information useful, because we must be aware this is a rare disease. So this is not very well known, and this is absolutely normal to know. That general practitioner cannot be aware of every rare disease. So this is very important to develop guidelines, and European guidelines, of course.
Indeed,
with conception, as we are doing at the time. Yes.
Yeah, I'm very happy for that, because it's very important. I think as Aniridia Europe, we are very keen on this topic. Now we got 2 questions from the audience. One is about the subject we were talking about slightly earlier. It was about medication for glaucoma drops, preventing or keeping the pressure in balance. And there was a question about if there is any limit of time or any time frame where you see that having this medication for a certain time of period can worsen the other developments like keratopathy and other things in the eye, or if there is no such thing. And also there was another question, I think I give you both few of them to you, and then you can choose who will answer them. I think the second one is maybe for Professor Käsmann-Kellner. It was about using glasses for reading, and I know you have seen the question, so you can decide who answered it. But this is two questions from our audience. Thank you.
Okay, I'll just take the first question concerning glasses. In respect of lenses, I don't quite understand the question because we have talked about contact lenses, and I assume the questioner wants to know about contact lenses. And the glasses are, of course, better for the corneal health and for the opacifications. Some patients really say that with contact lenses they see better, which I believe because they may reduce the nystagmus, the eye wobbling, and they may change the irregularities of the cornea better. But the disadvantages, they are just overwhelming, and so I really say do not take contact lenses, in spite of the fact that perhaps some of the affected persons say that it improves their vision, but it will worsen the vision in the long run. What I always advise is bifocal glasses, so that you have an enlargement for the near distance, which is very good in children as well when they start school, so that they have an enlarged text where they read and write. I hope this answered the question.
I suppose, and I really agree, no clearly contact lenses. We must be aware of the complication, not for instance, not for 1 week, but after, in the time, they will impact the cornea and will go to corneal opacification. And there is the second question, well, for the glaucoma medication. And with the glaucoma medication, which is important is to be preservative free. So that's the main problem, because in the balance we need to treat the glaucoma, because if you don't treat the glaucoma, you get badly impaired the optic nerve. So when we have a glaucoma, we need to treat the glaucoma, but we have to choose, of course, preservative free. Sometimes some molecules cannot be found with preservative free, so they will be the last molecules to be used, but the other are available in the market with preservative free. And so it's not the glaucoma medication that impair the cornea, it's probably the evolution of the disease. So in the meantime of the glaucoma medication, we use artificial tears. I mean, the sophisticated artificial tears on the market, because there is very brand new systems for these artificial tears. For instance, like Trialose getting better for the dry eye. And so we can use glaucoma medication to treat the glaucoma, and at the same time, artificial tears preservative free for both. And
but may I ask you then, Doctor, do you say that, now we have little drama here, do you really say that there is no impact on the cornea for long use of glaucoma medication?
No, I will not say that. I say we have to balance the treatment, and we know we have to treat the glaucoma. So, of course, if you put for years treatment of glaucoma, but if you protect in the other side, if you protect by putting some lacrimal tears, it can be balanced in this way. But we know, of course, that glaucoma medication, even preservative-free, can be toxic on the ocular surface.
Exactly. I think this is the key issue here. And actually, I don't think now most people, and I think it's very good you stress it, that it has to be that it has to be free from conservatives. But I think what many patients have asked us is that sometimes maybe let's say that they get high values in a moment, and then they get prescription, and then it's not really followed. So it means that sometimes patients, I think, feel that they having taking this medication, but it's not that they had acute glaucoma. They actually had some higher values once or twice, and then they don't feel convinced that they actually would have these problems. And that's why I think some patients have been asking these questions about how can we find this balance in the best way, because we do understand there has to be a balance, of course, but for instance, in Russia, they have this, as in a project, they have given out is it called eye care, I think, the small unit, so patients or some relative can measure the eyes at home more frequently, like
We have that in France too.
Yeah, like for traditional glaucoma patients. Yeah,
I suppose you have it also, Barbara.
Yeah, sure.
But do you use it for glaucoma patients? Because in Russia, this project, they do it for glaucoma patients. And would this be something interesting to investigate, maybe to do some research on glaucoma patients too? Because if there's actually no big problems with glaucoma, maybe then the medication can be adjusted. So that's the question.
You know, stressing patients is not a good option. I mean, you cannot take your pressure every 10 minutes, because if you can 10 minutes, sometimes your pressure could be very high, and after that could be down. So I understand it could be a good way if you use it like once a month, but not every day, because it will be you will be upset by the ocular pressure, and that's not the problem, because the diagnosis of glaucoma is not only the pressure, it's also a combination of thickness of the cornea. It's also a combination of the visual field. It's also a combination with the pressure taken with nystagmus. So the pressure taken with nystagmus is very difficult to interpret. So all of these, I think it will be an overload for the patients to have this to have this measure, because they don't have the other part of the diagnosis. And so they say, okay, well, that's a problem because I have 25. But if the cornea is sick, 25 is normal. And so I think this is better if you have the ophthalmologist that can just take all of these information and make the diagnosis to say, okay, we have to adjust the medication, or we don't have to adjust. This is good for me. Okay. And so eye care could be used, every month, but not more than this. So it's interesting. It could be useful for research, but not for every patient, because they will be very upset with the system.
Yes, I agree. It wouldn't be useful for every patient, but I do have some families with proven aniridic glaucoma in the children, and they have an eye care. And I think it's quite valuable if you have a line of ocular pressure, they can present to you when they come. And of course, even that is not the only diagnostic tool, and you have to look at the optic nerve head and visual field and the corneal thickness. But as I said, some families do measure the eye pressure regularly each day, and it might be helpful, but I would only do that in proven and glaucoma, which is difficult to treat.
Okay, that's a good option also, but maybe used cautiously.
Yes, definitely.
Yes,
And there is this other part of the question is, when do the glaucoma drops make the cornea worse? And I think this is as well a genetic question, because some genotypes of PAC6 aniridia, they are more susceptible to develop limbal stem cell insufficiency and corneal opacification. So I think in those where already young children develop the corneal opacifications, the risk of the eye drops is a bit higher than in patients who do not develop corneal opacifications very early.
That's very good.
Well, I don't know if you want to answer anything more about this, because I see that the time is running out. So please go ahead, but I also wanted to give you maybe a minute or two each to summarize some of your best advices also in the end, and then we will wrap it up. I will wrap it up. But who would like to start?
Dominique?
Okay, all right. Okay, I think we have been just looking at all the aspects of the disease, and congenital aniridia is really a panocular disease. I mean, it takes the entire eyeball and needs really a workup and a follow-up very precisely for children, and of course also for adults, with specific centers, with ophthalmologists, and it needs also a genetic exploration to understand all the possibility of the disease and to prevent. And in the prevention, I really think preservative-free artificial tears also are very useful. And the prevention also is to follow the pressure. And with that, I think we can understand more of the disease, and patients will be better in the evolution. And last time also be aware of the complication of systemic association also of the disease, and will be part of the checkup initial of the child. And so we want to work together with patients, association, researchers, ophthalmologists. We work together, and I think that's a very good point. Barbara, do you
Yes,
have something to
I
add?
agree with everything you said, of course, and I would like to add three things which are sometimes the patients are confronting us with, that are so-called edge filter, which are used against glare, and they alter the color sensitivity, and you should not use orange or yellow tinted glasses, because you take away the normal color vision the patient has. That's one point. The other point is we support our hospital, at least the maxim that every aniridia patient needs the best possible surgeon. So if we are feeling insecure, for example, in glaucoma surgery, we give the patient to another hospital. And I am sort of a guide for the aniridia patients, taking all the threads in my hand and then deciding where the best location is for the respective surgery. So this is, I think, important to mention that aniridia is not an easy surgery, and you really should try to get the best surgeons.
In centers specialized.
Yeah. Well, this has been very, very interesting to listen to. And of course, we have got a lot of questions, which we won't be able to take all of them today. I can see that there are a lot of questions about glaucoma, and I think maybe we can consider during the serial, during the autumn, maybe to have one specific about glaucoma and to discuss it further more in detail. But I think you have given very interesting reflections, very interesting advices, and also very valuable information and knowledge for the community, and also hopefully for some of the professionals watching. I'm very, very, on behalf of Aniridia Europe and Aniridia Net, I'm very thankful for your commitment and engagement and for your continuous work with these issues. Before we finish, I would like to give some small information to our listeners that, first of all, we have this campaign, Breaking Barriers, which collects stories of aniridics all over Europe who actually manage to break barriers, and you can read more about this in our social media channels or on our webpage, which is aniridia.eu. I would also like to say that we will have a first autumn seminar in the end of September, so please keep an eye out in our social media channels or on aniridia.eu webpage to see what will be the interesting subject and what will be the interesting guest for that seminar. And finally, we have actually something fantastically interesting which happens this summer, and that is that we have the 5th European Aniridia Conference. It's a scientific conference, but we also invite and have also sessions for patients. But it's focused on science and new research. And this time it will take place in London. And it is going to be possible to follow it online because of the pandemic. Unfortunately, we were not able to have it last year live, and it will be mostly online today. So please go into our webpage, aniridia.eu, and read more about the scientific conference, which I think would be most interesting for most people. Now, if nobody else has anything more to say, I would like to wrap this up to thank you all very much for joining us and for listening to us. And please stay in touch with us. We are on social media. You can find us on Facebook. You can find us on the internet, and you can also find us on YouTube. So please stay in touch. And once again, merci beaucoup and vielen Dank. And thank you, everybody.
You're welcome.
Bye-bye.
Thank you very
Thank you.
much.
Bye. Bye.